Hey guys, it's Sarah here. In this video, we're going to be going over everything you need to know for maternity for the NCLEX-RN. If you want this video or any other of my videos in a PDF or book form, please look at the link below and it will take you to where you could get it. So let's get started. Okay, maternity terms. So this one you need to know for anything in maternity. GTPAP. So what it stands for, G is for gravity, as you see over here. T is for term, P is for preterm, A is for abortions, and L is for living children. So gravity, let's start with gravity. So gravity is the number of pregnancies. So over here we go into a little more detail on about it. So basically, if they've never been pregnant before, it's called a nulli gravida. If they've been pregnant more than once, multi, so like the name says, and prime is like first, so they're pregnant for the first time. So that's what the G stands for. Then you go on to T. So T is term. So the number of term births. Term is considered 38 weeks or more. So just remember that, 38 weeks or more. So if the baby was carried for 38 weeks or more, then you would put a number after the T. Preterm is a number of pre-me babies. So preterm is basically from viability up to 37 weeks. Because like we said, 38 weeks and on is term, so preterm is before that. But it has to be from viability. Viability is the age where the baby could live out of mom, like out of the uterus. Obviously, it will need the NICU, etc., and will be sick, but it's a living being. So viability is 20 weeks. Just remember that, 20 weeks viability. Then we go on to abortions, the number of abortions. So abortion can be a regular abortion or it could be a miscarriage. And L is for living children, which is the number of living children a person has. So just one more thing that I forgot to mention, priority. So what people use is a GTPAL acronym, like I just went through. They also could just say GP, just for like short. And G is, like I said before, the number of pregnancies. P is priority, which is the number of births that reach viability, which is 20 weeks. Just remember, it's the number of births, not the fetuses. So let's say someone has twins. Twins are 2, but it's really considered 1 because it's the number of births. That mom only gave birth 1, even though she has 2 kids. So let's go over an example. So the patient is pregnant with twins. She has a 4-year-old who she delivered at 38 weeks, 39 weeks. No abortions or miscarriages. What is her GTPAP? So I'll give you a minute to just think of it. So this would be the answer. G2, T1, P0, A0, L1. So G, because there was 2 pregnancies. T for term, because only 1 was at term. P, there was no preemies, no abortions or miscarriages, and she has 1 living child currently. Okay, so physiological changes in pregnancy. These are all stuff that happen in pregnancy. Not every mom's the same. Some could have none, some could have all, some could have some. So let's go through it really quickly. So morning sickness. This happens from the hormones. You want to tell the patient to eat several times a day, eat snackers, bland foods, etc. Then we go into constipation. So constipation is very common in pregnancy, especially either they're not drinking enough or it's just common from like iron supplements that they're taking and an increase in the progesterone. So basically you just want to tell the patient to drink more, high fiber diet, exercise. Same thing you would tell any non-pregnant person. So the breast changes, so they're going to double in size. You should just let them know that. Decrease in blood pressure. So that's pretty common in pregnancy due to the dilation of the blood vessels. Urinary frequency. So this happens actually like towards the later stage, especially as the baby grows bigger, it's pressing down on the bladder, so they feel like they have to keep going. So that's normal. Skin changes. So some common skin changes that you should know is linear nigra, which is a dark streak midline down the abdomen. So it would be like straight over here, like straight down. It's darker. And that goes away about 6 months pretty much after pregnancy. Not for everybody, but for a lot of people it does. The next one is chloasma, which is brown hyperpigmentation, which is normal. These are all normal findings in pregnancy. And stria gravidarum, which is stretch marks. Then we go on to edema and varicose veins, which fall under the same thing. So this is very common in pregnancy, especially if they're standing for a long time. The blood pools down on their feet, and it's hard for them to come back. For this, you want to tell them to elevate their legs, avoid standing for a long time, compression stockings, etc. So you want to tell the patient to avoid the following things during pregnancy. Number 1, live vaccines. Live. So like the MMR, varicella are live vaccines. They could get not live vaccines like the Tdap and the flu one. They should also avoid anything like raw, unwashed, unpasteurized, uncooked, or like fish high in mercury. And they should avoid lying in a supine position, like straight flat out, because it could compress and they could go hypotensive. Other pregnancy education, just weight gain. Normal weight gain is 25 to 35, with people who are overweight gaining less and people who are underweight gaining more. They should take folic acid and iron supplements daily. Pica over here, it's basically an abnormal craving that they have cravings for things that are not normally eaten. So think of like ice, chalk, like things that are not food. Exercise, so it's actually recommended, obviously moderate exercise, not intense exercise. Balance, when we talk about balance, we are talking about that their center of gravity changes, like just because the belly's all out there, so, their back is going to curve and hurt them, etc. You want to tell them to perform Kegel exercises and tell them that the Braxton Hicks are completely normal. And what Braxton Hicks are is that basically they're kind of like contractions that could be felt, but they're completely normal. It happens later in pregnancy. They're painless and they're not like consistent. Okay, so then we go on to signs of pregnancy. So we have 3 different categories. We have the presumptive signs, which are subjective, so the patient's telling you. The probable signs, which are objective, so you see that. And the positive signs, which are absolute signs of pregnancy. So if you have the positive signs of pregnancy, then the patient is pregnant. So presumptive signs, so you have to know this, and NCLEX likes to test on this. Presumptive signs include missing their period, morning sickness, fatigue, breast changes, quickening, which is like fluttering movement that they feel. So these are signs that if a patient has it, it could indicate pregnancy, and this is based on what the patient's telling you, subjective. Then we go into the probable signs, which are objective, so you as the examiner note this on the patient. The first one is called Godel sign, which is softening of the cervix. The next one is called Hager sign, which is softening of the lower uterine segment. The next one is Chadwick sign, which is like a blue-purple color of the cervical and vaginal mucosa. Then we have the Braxton Hicks, like we said before, like the painless contractions that's not consistent. Positive pregnancy test. And ballottement, which is basically when you use a finger to push down the uterus to see if like the baby moves back and forth to you. The positive signs are the only ones that are the absolute confirmation of pregnancy test. Number 1, fetal heart tones. You hear it. Number 2, seeing the fetus on ultrasound and feeling the baby through like palpation when you palpate. Okay, so here we go into a question. So which of the following is indicative of a probable pregnancy? So probable. Morning sickness, fetal heart tones, breast changes, or Chadwick sign. I'll give you some time to figure that out. So the answer is Chadwick sign. So just how I like to remember all these stuff is that the presumptive ones is what the patient's telling you. I don't have my period anymore, fatigue, whatever, breast changes, etc. The middle one is all those like weird ones like Chadwick, Goldell's, like stuff that you wouldn't know, you just have to memorize. And then the last one is like it's only 3 stuff. So heart tones, ultrasound, stuff that you could actually see or hear the baby. Okay, fetal tests. So these are just tests that we do in maternity, and I'll just go through them quickly so you know what they are. And you have to know them for the test. So the Leopold maneuver. What this is that it's basically, look, I actually put pictures up here. So it's basically when you palpate the pregnant abdomen, so you identify the fetal position. So see how the doctor over here is trying to feel, is the head there, is the butt there, like trying to figure out where it is. Obviously before starting, you want them to empty their bladder because, you know, that'll help them go. And it's usually done after 24 weeks when the baby's big enough to do that. The next one is fundal height. So over here, as we see, this is a good indicator, or like basically it's a measurement of the size of the uterus. So it's basically telling you how the fetus is growing. So like I would know this one. At 20 weeks, the fundal height should correlate with the number of weeks pregnancy. So if the baby's 20 weeks, then the fundal height will be 20 centimeters, etc. So 24 centimeters, 24 weeks. So that you'll see if the baby's growing good. The next one is the nitrazine pH test over here. So that's basically a test to see if the amniotic sac ruptured. So basically they take a strip, they insert it into the vagina, and if it's blue, then it's positive. So then the membrane did rupture. If it's yellow, then it's negative. This is going to help differentiate between amniotic fluid and vaginal fluid, because a lot of times people don't even know that they passed that, like it ruptured. Just know for this that semen or blood could cause a false positive. Next we go on to Bishop score. So the Bishop score over here is used to assess and rate cervical readiness for induction. The higher the score, the better chance of successful induction, basically. So basically you want like a high score, like over 8. Fetal non-stress test, this is very common. So this is actually done after 28 weeks of pregnancy, and basically it's just seeing how the baby's doing. It's non-invasive. They monitor the baby's heartbeat, movements, the mom's contraction. It's usually done when the baby's overdue, or let's just say you came in and you say, I don't feel my baby. So then they do that to make sure the baby is contracting, that the uterus is contracting and the baby is moving. The next one is a biophysical profile, which is like called a BPP, so biophysical profile. It's an ultrasound to assess the fetus in 5 different areas. So it assesses the fetus breathing, movement, tone, amniotic fluid, and fetal heart rate. I wouldn't really know like what it says. Just remember it's an ultrasound that's usually done with the non-stress test to see how the baby's doing. And it's done either when someone's overdue or if there's a concern, which is why you want to see how the baby's doing. Next, we go on to Group B Streptococcus, which is GBS. And basically, it's a bacteria that a pregnant mom could have and could pass on in delivery to the baby and be harmful. So basically, when the mom is like 35 to 37 weeks, they test it. If the mom's positive, they give her antibiotics during delivery and just to make sure. The next test is indirect Coombs test, which is basically, so what happens is that if there's a trauma, let's say a car accident, for example, it could cause bleeding and the mixing of the bloods. So if the bloods do mix, and the mom antibodies could attack the babies. So basically after the trauma, you want to do this indirect Coombs test and see if the mom is negative and then the baby's positive like that, then you want to give them immunoglobulin. Next we go on to Nagel's rule. So Nagel's rule is basically to estimate the date of birth. There's a whole calculation like that. Basically, I'll say it really quickly. is calculated by taking the last date of mom's menstrual period minus 3 months and plus 7 months. If they conceive in January, February, March, then it's the same year. Otherwise, it's the next year. The next one is chorionic villi sampling. It's basically a test for genetic abnormalities done in the first trimester, so usually around 10 to 12 weeks. The next one is an amniocentesis, which is done around 15 to 17 weeks. It's basically when a needle is inserted in the abdomen to get amniotic fluid. They send the fluid to the lab and they test for other genetic abnormalities. PUBS, which is percutaneous umbilical blood sampling, is done in the 3rd trimester. It's basically they puncture the umbilical vessels with a needle and they get the fetal red blood cells, and they want to see if there's problems that are happening from the blood interacting. So those are all the tests you have to know that they do during pregnancy. Okay, so next we go on to pregnancy complications. So the first pregnancy complication is gestational hypertension. So this is a new onset of high blood pressure. This has to be after 20 weeks. This is not like you had blood pressure before and now you have blood pressure but you happen to be pregnant. This occurs after 20 weeks of pregnancy, and hypertension, no protein in the urine, just hypertension. Once they have protein in the urine with hypertension, it's called preeclampsia over here. It's a more severe form, and the problem is it could lead to eclampsia. Just remember, like someone seizing, like eclampsia is basically when they're having seizures. So the symptoms of preeclampsia, are high blood pressure, protein in the urine, like I said. The goal basically in this stage is to prevent it from getting to eclampsia. So you want to give them magnesium sulfate and assess a deep tendon reflexes hourly. The only cure for preeclampsia is delivery. Just know that. HELP syndrome is a complication of this, and the acronym of HELP syndrome basically tells you what it is. It's hemolysis, elevated liver, like that whole acronym is basically what it could lead to if it doesn't get treated. It's hemolysis, elevated liver enzymes, and low platelet count. It's a really severe form of preeclampsia, and it's really dangerous, So more pregnancy complication, hyperemesis gravidarum is basically when they keep vomiting and throwing up. The problem with vomiting in general, and this vomiting in pregnancy, is that could lead to dehydration, and it could lead to an imbalance of electrolytes. So what you want to do, so the symptoms are going to be the dehydration symptoms because they keep vomiting and losing fluid, and you want to correct if they haven't, tell them to drink and eat and correct their imbalance. Ectopic pregnancy is a big one. Ectopic pregnancy is basically, as we see before, in a normal pregnancy, the fertilized egg, so once the sperm and the egg fertilize, they implant themselves in the uterus. Ectopic pregnancy is the same thing, except for it implants itself in a place where it cannot grow and become a fetus. So you see over here, most commonly it's in the fallopian tubes, which are over here. Symptoms are going to be lower quadrant abdominal pain on one side and a little bit of vaginal bleeding. Or they can even have like a palpable mass in that area. The problem with ectopic pregnancy is that it could rupture and cause a hemorrhage. So you want to treat it, you want to remove the embryo. It's not viable. It can never become a baby. Molar pregnancy, which is also called hydatiform mole, is basically like a non-cancerous tumor. It's a tumor in the uterus, but it's not cancerous. But it causes a woman to have exact same symptoms as pregnancy, but there's just no fetus. So like we said before, that's why it's so important with the presumptive, probable, and the actual signs of pregnancy, because you have to actually hear the fetal heart rate or like visualize a baby for it to be pregnancy. Because in molar pregnancy, they can have all the other symptoms. They can miss the period, positive pregnancy test, etc., but they're not pregnant. And it has to get, and the treatment is to remove the tumor. Another pregnancy complication is supine hypotension syndrome. It usually occurs in the 3rd trimester. It's basically when you lay down and the weight of the, because you have a big abdomen, is compressing the vena cava, causing hypotension and tachycardia. What you want to do is you want to immediately reposition them and turn them to their side, so that the pressure goes off the vena cava. Okay, so here is a picture and a summary of fetal movement. So fetal tachycardia is when, just like regular tachycardia, when it goes too fast. It could be caused by infection, fever, etc. Fetal movement, when the baby moves, is a sign of health. It should always be felt and always be there. Once the baby stops moving, it's a concern. So there are different factors that could affect the movement, faster, slower, or none, like if someone's fasting, medication, drug use of the mom, or even if the baby's sleeping. So fetal movement should not decrease in size as the baby increases in size. In general, you want around 4 movements per hour, and if there's a decrease, then it could indicate fetal compromise, like the baby doesn't have enough oxygen, etc. And then they would do a non-stress test, like we said before. So acceleration. So basically, accelerations means that there's basically an increase in the fetal heart rate. So you're going to see it go up like that. This is good. This is, and you don't have to do anything for it. The problem is decelerations, like you see over here in the back. Decelerations are a decrease in fetal heart rate below the fetal heart rate line that you want it to be at. So there are 3 different types. Number 1 over here is early decelerations. We have variable decelerations and late deceleration. So over here is a hint. If you look over here, it says Vil chop. So variable means that the cord is being compressed. E stands for early. Early deceleration means the head is compressed. And A is for accelerations, is okay, so they're good, don't do anything. And L is for late, placental insufficiency. So early decelerations, as you see over here, here's baby's heart rate, here's mom's heart rate. As the mom contracts, the baby's heart rate dips. And after that, it returns to baseline. This is normal finding. It means the head is being compressed as it contracts, and there's nothing to do, just monitor. Variable, it actually looks like a V for variable, so that's easy. See over here, V for variable. And basically, it's when the umbilical cord is compressed. What you want to do is that you want to change the mom's position because you want to relieve the cord compression. You give them oxygen, etc., and tell the doctor. Late decelerations are really the one you want to watch out for over here. This means that there's a decrease in heart rate that begins after the contractions. So see over here, mom's contracting and then baby dips after. Mom's contracting and then baby decreases. This means that there's not enough oxygen to the baby because it's placental insufficiency. So this you want to treat right away. You want to change your mother's position, give oxygen. If they're getting oxytocin, stop it and tell their provider right away. So here's just a summary over here, and here is the hint. So here's a question. Which fetal heart rate would be concern for the nurse? Accelerations, early decelerations, late, or fetal heart rate of 126? I'll give you some time. C is late decelerations because it means that the placenta insufficiency. The baby needs oxygen. I'm sorry. Okay. Stages of labor. So these you have to know. I may have to know everything pretty much that I'm saying, but this you really should know. The stages of labor. So you have the first stage, the second, the third, and the fourth, and then under the first, there are 3 stages. So the first one is when the cervix goes from 0 centimeters dilation to 10. Under this is divided by early, active, and transition. So early is when the mom is 0 to 3 centimeters, the pain is managed, she's like, oh, this is fine, I'm so excited for the baby. It's a great time to tell her direction because she's mentally there, not in a ton of pain, so she can listen. The next one is when they're active, so that 4 to 7 centimeters is when their pain is increasing, they're getting more serious, it's hard for them to follow instructions, they're concentrating on the pain, and yeah. The next one is transition, when they're 8 to 10 centimeters, is when they're starting to get rectal pressure, they're feeling urge like they have to go to the bathroom, when they really don't. They're in real pain, fear, anxious, and just not a good time. After that, we go on to the second stage. So it goes from full dilation, so 10 centimeters until the baby is delivered. So you can only start pushing when they're 10 centimeters. So basically, this is the pushing stage. The third stage is as soon as the baby is delivered until the placenta is delivered. So after the baby comes out, the placenta is still attached to mom. That has to get delivered after. So that's the third stage. The fourth stage is after the placenta comes out until a few hours after. Okay, so now we go into fetal positioning. So, okay, so there's a few parts. There's the presentation. So this is basically which part of the baby is entering the birthing canal. So like just if you would look into like the mom, like vaginal area, which part do you see? Do you see the butt, the head? Which part do you see? A hand. So there's different ways. So number one is cephalic, which is the head is entering first, which is the what you want. You want the head first. You also have breech, which is the butt is first in the vaginal canal. There are different type of breech, as you see over here. There's frank breech, which is basically the most common, where the baby's hips are flexed and knee joints are extended like this. Complete breech, which is the baby's hips and knee joints are flexed, and foot lean. So see how like there's a foot. There's also shoulder presentation, is when the baby is transverse, so it's like this, and you're going to need a C-section. There's no way to birth someone through the vaginal canal when they're transverse, unless the baby turns. Another fetal position is lie. So what lie is how your fetus spine is lying in relation to the mom. So here's the mom. How is the fetus's spine? Is it the same way as the mom? Is it transverse, which is horizontal, or longitudinal, which is vertical? The presenting part is basically the part of the fetus that's closest to the cervix, which part is presenting, coming out. The position. So the optimal position, like we see over here, is ROS, so the right occiput anterior. So it's basically head first. Occiput posterior, which means that the baby is turned. So you see over here, like you want the baby like this. The back is coming out. If it's the other way, then the mom's going to have intense back pain. It's going to feel like labor in the back. If this happens, you want to apply pressure to the sacrum and position the mom on head and hand on knees. Hand and knees position. What gestation is basically how far the fetus's head has descended into the canal you see over here on the top. So it starts from negative like 3 or 4, and then it goes to positive 3 or 4. 0 means it's engaged. It's at the ischial spine, and it's considered engaged. 5 plus, like when it's like over here, 4 or 5, it's considered crowning. You see the baby's head, it's coming out. Okay, so labor, true versus false labor. So this is a big one. So one of the ways you know if mom's in true labor or false labor is going to be by the contractions. If they're regular, so let's just say every 10 minutes or every half hour, then it's true labor. If they're irregular, so false labor is going to have contractions 10 minutes and then 12 minutes and then half hour and then 10 minutes. It's going to be like irregular. Another big thing, which is the cervical changes. If there's no cervical changes with the contractions, then it's false labor. If there is cervical changes, then it's true labor. And also the intensity. True labor is going to get more intense as it goes on. False labor is not going to. So then we go into assisted devices, forceps, and vacuums. So they're used like in fetal distress, like if while the mom's pushing, the baby's heart rate decelerates or something like that, and they need to pull the baby out. Or mom needs help, mom's fatigued, etc. So they'll use these assisted devices, and it'll attach to the baby's head, like over here, it's like a suction over here, or they'll use like forceps, and they'll basically pull the baby out. So the baby could have kappa succedaneum or even like a cone-shaped head, and telling mom this is normal, it's going to resolve, it's just from the assistive devices. Preterm labor. So this is labor before 37 weeks, because remember we said 38 weeks is term. One of the biggest risk factors are infection, so like urinary tract infection, etc. Or drugs could do that. What you want to do to prevent it is a cerclage. What a cerclage is basically, I would know this, is putting sutures to keep the internal cervical os closed. It's placed at like 12 to 14 weeks if a patient has a history of cervical insufficiency, and it's kept in place until like 37 weeks when you don't mind if they deliver. Symptoms of preterm labor would be like lower back pain, contractions, pelvic pressure, or the member is ruptured. What you want to do is give them tocolytics and steroid injections that in case they do deliver, the baby's lungs could hopefully be mature. And obviously you want to monitor the mom, and if it's caused by infection, treat the infection. Presupinous labor is basically a really quick labor. So it's one that happens from onset of contractions 3 hours later, the baby's out. So they'll have symptoms like involuntary veering down, like they can't help it, etc. So here's a question. The nurse is taking care of a woman in labor. Which finding indicates that the woman is beginning the second stage of labor? Regular contractions, clear vaginal fluid, ruptured membranes, completely dilated cervix. So I'll give you a minute. So the answer is completely dilated cervix because, like we said before, the second stage starts when the mom is 10 centimeters. Okay, so here are medications used in labor. So number one is oxytocin. That's very famous. It stimulates contractions. So it's used for either postpartum to prevent hemorrhage or to cause labor, so like an induction. It's given through a pump, and you want to watch out for uterine tachysystole. It's basically when it's too fast. The next one is narcotics. So remember, mom's going to be in a lot of pain, so you want to give narcotics. But with all narcotics in general, not just for pregnancy, you want to watch out for respiratory depression. So you want to give it at the peak of contractions, so less narcotics get to the baby. Another medication is a pudendal nerve block. So basically, like an epidural and stuff like that is not given when the baby is like about to be born. So if the birth is imminent, this is the one that you want to give because it's the least maternal and newborn side effects. The next one is epidural. So an epidural is basically given in the first or second stage of labor, like I said, not right before birth, because it takes like 20 minutes to even get through. It's basically you insert a needle into like the 4th and 5th lumbar vertebrae, and the most common side effect is hypertension. So you want to watch out for hypertension, and usually they'll give it they'll give like a bolus of fluids before so the person doesn't go hypertensive. Another medication is tocolytics. So these are used to suppress premature labor. So if mom comes in at 30 weeks and she's in like labor, do you want to suppress labor, you give them tocolytics. This includes terbutaline, magnesium sulfite, indomethacin, and nifedipine. It doesn't prolong labor that much. It prolongs labor around like 2 to 7 days, but it gives you enough time to give a steroid to make the baby's lung mature so that when they come out, at least it'll be a little mature, so it could breathe. Another class of medications used are uterotonics, which are given to increase labor contractions. This includes misoprostol and methergin, which is also used to treat severe bleeding postpartum. And last but not least, magnesium sulfate is given for preeclampsia, so to prevent seizures, and is also used to treat hypomagnesemia, but that's not specific for pregnancy. Okay, so labor complications. So one of the labor complications are shoulder dystocia. So this is basically when the head comes out and goes back in. It's actually called turtle sign because it's like a turtle. You know how a turtle has like a shell and it peeks itself out and it comes back in? So that's exactly what the baby does. Peeks it out, comes back in. This is actually an emergency. Once the baby comes out, it can't just go back in. It got to come out. So the treatment is that you do McRoberts maneuver, which is like right over here. It's basically the mom's legs are held in a flexed position, pulled to her chest, and you're applying suprapubic pressure to get the baby out. This usually happens with like big babies. The next labor complication is meconium aspiration syndrome. So it's a type of aspiration pneumonia. It's basically when the meconium is basically the baby's pooped instead of out of, like in the real world, they're pooped in uterus. So the first stool is supposed to happen out, but it pooped in uterus, so the risk is that when the baby comes out, it could aspirate in the lungs. So if this happens, you need like the resuscitation team at birth in case the baby swallows it. Another labor complication is VBAC, which is basically vaginal birth after C-section. So usually with a C-section, once the mom has a C-section, it has an increased risk of uterine rupture. So you don't want to induce this patient or make them go into labor quickly to do a vaginal birth. And a lot of doctors won't do a vaginal birth after C-section. The next complication is uterine rupture, which is basically you're going to see signs of abnormal fetal heart rate, consistent abdominal pain, a loss of fetal station, and contractions. Okay, so some other complications are umbilical cord prolapse. It's basically when the umbilical cord comes out before the baby. This is a medical emergency because the way the baby gets oxygen is from the umbilical cord. So it can't come out before the baby does because the baby doesn't have oxygen. So this is a medical emergency. The way you know it is because you actually see the cord coming out. What you want to do is that you want to manually elevate the presenting fetal part of the cord. And you leave your fingers in there, call for help, place the patient in knee to chest position to relieve the pressure, give them oxygen, and bring them right to C-section. Never push the cord back in. The next complication is called PROM, which is premature rupture of membranes. It's basically when the mom's water breaks before the onset of labor, so before 37 weeks of gestation. It doesn't harm the fetus, but if labor doesn't begin after the membranes rupture, then you need to induce labor because there's a risk of infection, which is actually called chorioamnionitis. The next one I want to talk about is polyhydramnios, which is basically too much amniotic fluid. Okay, so here are other complications. Placenta abruption, placenta accreta, and placenta previa. So in quick, the short thing between them is placenta abruption. The placenta separates from the uterine wall. As you see from here, separates from the uterine wall. Placenta accreta, which is basically placenta grows too deep into the wall. And placenta previa, which is the placenta, as you see over here, is over the cervical opening. So placental abruption, it could be partial, like, it separates partially, it separates completely. Symptoms will be abdominal pain, uterine contractions, and the main one is dark red vaginal bleeding. So with placental abruption, there's bleeding. With placenta previa, just remember painless bleeding. So abruption is abrupt, painful bleeding. Placenta previa is painless bleeding. For placenta abruption, when the placenta separates from the uterine wall, you want to monitor the fetus. You want to watch the mom for signs of shock, and you may need to give them blood or fluid. For placenta accreta, when the placenta goes too deep into the wall of the uterus, it could cause hemorrhage. You want to watch out for that. Placenta previa is when the placenta, like I said before, is over the cervical opening. So if it's found early, like it usually resolves itself. If it continues after like the second trimester, etc., they may need a C-section. But basically, the treatment is basically a planned C-section at like 36 weeks or whatever. Postpartum assessment. So there are stages. The stages in postpartum are take it in, take hold, and letting go. So just remember, you breathe in, hold it, and then let go. So breathe in, which is taking in. It's for the first 24 to 48 hours postpartum, and it's when the mom is physically recovering, completely dependent on the healthcare team to take care of her baby. After that, they hold it in. It's 2 to 20 days postpartum. So the mom's learning different skills of motherhood, but she doesn't feel like adequate to be like by her own alone. And after that goes the letting go stage. After 10 days of giving birth, the mom's comfortable and knows what to do. Another thing postpartum is you want to watch out for the leukemia, which is basically discharge of blood. So this you have to assess it. So the mom's going to be wearing a pad and be bleeding after birth. If she soaks a pad under an hour, this is concern. This is considered excessive bleeding and it should be reported. There are different types of bleedings as we see on the side. Leukia rubia, so it's going to be like this color, bright red. It's until the first 3 days of postpartum. I would know this. Leukia serosa, which is like this color, which is like a pink brownish color. After 3 days till 10 days of postpartum, and then it's going to be Leukia alba, so think of like white, like alba, like Albanian, from after 10 days till 15 days of postpartum. Then we go into the uterus. The uterus after postpartum, it begins to like shrink itself, which is called involution. It shrinks itself back to the pre-pregnancy size, or at least close. It should be contracted in midline and slightly below the umbilicus. The thing you want to watch out for is atony, which is like boggy, displaced uterus, and it could cause hemorrhage. And you want to do a fundal massage. And last but not least is adoption. So if mom wants to put the baby up for adoption, you want to let everyone know that that's happening, so no one says something like the wrong thing to the mom. And just remember, the adoption's the decision of the mom. It's not your decision. It's not neglect or anything else like that. And you should give the mom like a chance to make memories with the baby if they want to. Okay, question. So you're the nurse who's going to see a woman who delivered 2 weeks ago. Which symptom is normal? So 2 weeks ago, she delivered. Her baby's 2 weeks old. Leukia alba, hypertension, soaking a pad in an hour, or cracked nipples? The answer is lochia alba. Like we said, that happens after 10 days to 15 days, and it's white in color. Okay, postpartum complications. So postpartum hemorrhage is basically when they lose more than 500 ml after a vaginal birth or over 1,000 after a C-section. There are two types of hemorrhage, early and late. Early is that occurs less than 24 hours after birth, and delayed is, or late is when it occurs after 24 hours of birth. If it occurs in the first 24 hours, it's usually caused from a boggy uterus, uterine atony. And that, like I said before, we do the fundal massage, we help them pee, etc. If it occurs after 24 hours of birth, then it's usually caused by retained placental fragments, and you need to do a DNC to remove it. The next one is postpartum endometriitis. Like the name said, it's an infection, itis, of the uterus. They're going to have regular infection symptoms like chills, fever, tachycardia. They're going to have cramping, etc. So here are 3 different types of postpartum complications that we're going to divide like this, so it's easier for you to see and understand what the difference is. So postpartum blues, postpartum depression, postpartum psychosis. So postpartum blues are very common after giving birth. Within the first 2 weeks of giving birth, they're moody, irritable. For that, you want to just give them help. You know, it's a lot to have a newborn baby, taking care of them. They wake up, they have different schedules than you. Just give them resources. It will go away. Postpartum depression is not that common. It's only 13%, but it happens between the first year of giving birth. Symptoms they'll have is depression. They can't feel a bond with their baby. They have anxiety attacks. They could even be suicidal. For them, you want to always assess for suicide, antidepressants, and it does not go away itself. You have to treat them. Postpartum psychosis is very rare. It happens in the first 3 months of postpartum. They have severe mood swings, delusion, hallucinations. They need to be hospitalized. They can even attempt to harm their baby or themselves. They need hospitalization, long-term care, psychiatric evaluation. That's a scary one. Postpartum complications, some of them include breast engorgements. So basically this is when the mom breasts like fill up and just get too large and it hurts them. This could be because the mom's producing more milk than the baby's eating, or other stuff like that. If the mom is not breastfeeding, you want to help her reduce her milk because she doesn't need the milk because she's not going to breastfeed. So you could put like cold compresses on, anti-inflammatories, etc. If the mom is breastfeeding, then you want the mom just like manually express the milk or feed the baby more frequently. The next one is mastitis, which is basically an infection in the breast tissue that causes the milk duct to be clogged. This is regular symptoms like fever, infection symptoms, and breast pain, because that's where it's happening. So like it's an infection, so you give them antibiotics, and that's that. So here's a question. 7 hours after labor, a woman refuses to feed her baby. She says she's too tired or needs to sleep. What should you do first? So should you tell her that she needs to feed her baby first? Take the baby back to the nursery and tell her she could rest? Tell her she's in the taking hold stage? Record this as a nursing diagnosis of ineffective mother. The answer is you take the baby to the nursery and tell her she could rest. The mom needs to be good in order to take care of her baby. She's only in the taking hold stage, so it's only 1 week after birth. This is normal. Okay, now we go on to the newborn. So newborn assessment, it's going to start at APGAR. What APGAR is that it's a quick way to assess the newborn right after birth. It's done at 1 minute and at 5 minutes after birth. It assesses, like I said over here, appearance, pulse, grimace, activity, respirations. 8 and up is great, and most babies don't get a 10, so 8's normal. Okay, newborn assessments. So these are normal newborn findings. So normal newborn vitals are found on page 5 of my notes. Like I said, you could always access my notes in the comment section below or at my website, www.sararn.com, and check on my notes for this. The breathing could be slightly irregular, diaphragmatic, or shallow, but these stuff are abnormal, like nasal flaring, retractions, seesaw respirations. Those are abnormal. Physiological heart murmur in the first 48 hours of life is normal. After that, it's abnormal. After the baby comes out, crackles are normal because of fluid, but like wheezing, stridor, abnormal. Mammillary gland enlargement is normal. It's because it's from the high exposure to estrogen from the mom. Non-purulent vaginal discharge is normal. Mild uterine withdrawal bleeding is normal. And jaundice. If jaundice happens after 24 hours after birth, then it becomes pathological and then it's not normal. You could feed them and help them that way. Newborn assessment. So when you're looking at a newborn, Lenovo is fine hairs that are present, like you'll be like, wow, the baby is very hairy. This is usually found in pre-me babies. It disappears after like 36 weeks of gestation. So here's a little bit difference between preemies and full term. So like a preemie at like 28 weeks versus a full-term baby. So the breasts are not going to be raised with preemie. They are going to be raised with full-term. Preemies are going to have pink, smooth skin. Full-term are going to have like dry, peeling, like raisiny skin. Preemies are going to have smooth with only faint red marks or single transverse crease, and full-term are going to have creases. Newborn assessment. So acrocyanosis is basically cyanosis of the hands and feet of the newborn. It's normal during the first hours of birth. It's basically poor perfusion to the peripheries. You want to place the newborn skin to skin or in a radiator for that. Newborn stool. The first stool the baby makes is called meconium. Meconium should be passed in the first 24 hours of the baby's life. And after that, the stool is going to be like yellowy, brown, green stool. That's normal. It's going to be like more firmer and brown if it's bottle fed and more like yellowy, pasty if it's breastfed. Cryptocysm, however you pronounce that, is basically when the testicles are not descended at birth. This is completely normal and they usually come down at 6 months of birth. 6 months old. Hypoglycemia, if the mom has gestational diabetes and the baby's at risk because it's used to all this glucose and then it's coming out and now it's going to drop. So the treatment is you want to feed them right away. Question, what's your APGAR score? The heart rate is 130, the baby has a pink body, hand cyanotic, weak cry, flexion of the arms and legs, active movement, and crying when stimulated. So here's the answer, and it goes based on, you're going to check off the boxes, and that would be your APGAR score. Okay, so here we're going to go on to newborn skin findings. So erythema toxicum is very common, as you see over here on the right side. They're firm, white, yellow. They're basically like pustules surrounded, like they're red pustules. It usually appears the first 2 days of birth and resolves within like 5 days. No treatment necessary. Very common. Mom may freak out, but very common. The next one is Epstein pearls, which you see like these white little dots over here, like on the hard palate of the newborn. It's completely normal and will disappear after a few weeks. The next one is a Mongolian spot. So these are like flat bluish discoloration on the lower abdomen. It's benign and it fades over the first 2 years, but you want to measure them and document them, because then someone's going to think it's like abuse or something like that. Always document your findings. Some other stuff is vernic caseosa, which is over here, which is basically like a protective substance that covers the fetus, and it's like white, waxy, cheesy appearance, and it's usually found in like the genital area of term newborns. So these are all stuff that aren't newborn findings but are normal. The next one over there is milia. Milia. It's as you see, this is a baby's nose. It's like tiny white little like spots. They're usually found on the nose, maybe chin also, and they go away themselves. So you should know the difference between kappa succedaneum and cephalohematoma. So kappa succedaneum, CS, does crosses sutures. It's basically edema of the soft skin scallop. It crosses the suture line, the edema. It goes away in a few days. You don't need to do anything. Just know about it. Next one is cephalohematoma. It's a collection of blood between the baby's skull and scallop. It does not cross the suture line, and that one you want to watch out for. Some newborns' defects are Down syndrome. So Down syndrome, I would just know the appearance of a Down syndrome baby, so you can know what it is. It's basically they usually have a single transverse crease on the palms of their hands. They have lower ears, a flat bridge nose, protruding tongue, and hypotonia, like they're not as active. The next one is, so we know what the Zika virus is. It's basically from mosquitoes. It's a virus, but it's linked to birth defects. So what it causes is a small head, which is over here, which is called microcephaly. Anencephaly is a severe neural tube defect that causes like no brain tissue or skull formation. They're really not compatible with life. So it's kind of like comfort care. Okay, so newborn defects. So fetal alcohol syndrome is basically when there's alcohol exposure during the mom's pregnancy, and it causes the baby to have intellectual and developmental delays. It's very unfortunate. Neonatal abstinences syndrome is basically when the baby in the womb got so used to drugs like opioids, etc., that like when it's leaving the place with drugs, because that's what it's used to, it has like withdrawal symptoms. Usually starts like 24 hours to 48 hours after birth, because that's how many hours usually withdrawal. And treatment, you want to swaddle the baby, treat the symptoms, minimize stimulation, etc. So here's just talking about infants from 0 to 1 years old. So for them, so iron's a big one. Premature babies need iron supplements around 2 to 3 months. If an infant is only being breastfed, then the iron levels drop at 6 months. So they need supplement by 6 months. The weight, length, and height, as you see over here, here's a chart from the CDC. So just key this to memory. They like to ask these things. I'm just going to read them off. The baby's weight doubles by 6 months, triples by 12 months. The length by first year increases by 50%. The head, at birth, the head circumference is slightly more than the chest circumference, but equalizes at 12 months. So the fontanelles, they're going to be like over here in the front and one in the back. And they should be flat, soft. It's normal to see them bulge when the baby's crying or coughing, but if they're bulging when they're not crying, when they're calm, that's a concern. You should also know when they close. The front one closes at 18 months. The back one closes at 2 to 3 months. So here's just some information to like patient education for infant. Formula, you want to test the temperature with your inner wrist before giving it to them. Never over dilute with water. Never microwave. Never leave extra formula like in the bottle. Always throw it away. In the baby's first few days, like 3 to 4 day old, weight loss of 5 to 6% is normal. It should return in a week by like 7 to 14 days of life. If it has more than 7% of weight loss, then it should be evaluated. Umbilical cord care. So usually moms don't know about this. So basically the cord starts to dry at 24 hours and it shrivels and then turns black. So it separates from the umbilicus around 1 to 2 weeks after birth. What they should do is that they should fold the diaper right under the cord so it's not covering it and like the feces don't get in the cord, because you want to keep the cord dry and clean. Do not put alcohol swabs in them. They used to be doing that. Now it's not evidence-based practice anymore. And you want to report symptoms like of infection, like swelling, redness, etc. SIDS. So to prevent SIDS, which is sudden infant death syndrome, you want to just make sure the baby can't like choke them like themselves. Like don't dress them too much. Don't put stuff in the crib that they cover them. Make sure, don't overheat the baby, etc. So car seats, they should always be rear facing. In the back of the car, they should be at a 45-degree angle. Make sure that they fit tight, they're not too big, no bulky jackets or blankets, etc. So here are reflexes that you should know with a baby. They're very into reflexes, so I would know this. So, basically, the Babinski reflex, you can even like Google a video and see it really quickly. It's basically if this is the foot of the baby, you stroke it, and the baby's toes should fan out like that. It should go away at a year. If it continues at a year, that's not good. Or if that doesn't happen, then it's not good. So grasping is basically when you touch the baby's palm, they should grasp your finger like that. It should go away after 6 months. The moral or startle reflex, exactly as the name says, startle. So you bang something, the baby like goes like that, like that, it should go away after 6 months. The rooting reflex is when you stroke the side of the baby and then they turn like that to try to like eat you and suck. It should disappear around 3 to 4 months. The stepping reflex is when you hold the baby like up like this, the baby's feet are here, and they should try to like move and walk. So that should disappear also at 6 months. 3 to 4 months. So here's a question. The nurse is assessing a newborn's reflex. Which action is appropriate to elicit the moral reflex? So we said the moral one is a startle one. So either you make a loud noise, or you stimulate the ball of the foot, you stimulate the perioral cavity, or the pads of the newborn's hands. So the answer is the answer is A. The moral reflex is the one with the startle one. So that's it. Thank you so much for watching. First of all, if you want this video in a book or PDF form, click on the link below or visit my website, www.sararn.com. And please like and subscribe, and I'm going to be posting the whole NCLEX review series up front for you guys. So thank you for watching. Like and subscribe.